Okay, everybody, we're going to start talking about CBCT techniques and applications. You know, CBCT is really becoming something that is a standard of care. The cost has come down, and its abilities are so important in dentistry that it is becoming something of a standard of care. When we finish this class, we should be able to describe the technology and how it's different from other imaging. We are going to talk about some scenarios when you might need a CBCT as your image of choice. We're going to talk a little bit about limiting exposure, and we're going to review and interpret some CBCTs so that you kind of get an idea of the anatomy in this modality. And we're going to, of course, during this, talk about some ethical and medical legal considerations of CBCT. So the first most important thing is talk about the three big advantages of CBCT, which are, first of all, that it's three-dimensional, because three-dimensional is really how you examine a patient physically when you do a physical exam. And of course, everything that we do in the body is 3D. It helps you better because with that kind of depth of detail, you can do more precise planning, more precise diagnostics. And it's really crucial when we do complex procedures. So obviously in simple procedures like a filling or cleaning, you don't need that most of the time. But when you start looking at the dental anatomy for dental implants, for surgery, for extractions, anything that has three-dimensional anatomy that you need to interpret and work in, then really this significantly impacts your results. Now, CBCT, dental CBCT has lower radiation when you compare it to a conventional CT, a hospital CT. So these new devices we use in our offices are much lower doses than the medical CT, but it does expose the patients to more radiation than a traditional kind of CT, X-ray. So if we're talking about a panoramic or a PA, obviously a CT is multiple panoramics, but compared to a medical CT, it's much lower radiation. Another great thing about our dental CTs is that you can just do small regions. So you can literally do 3 or 4 teeth, a quad. You don't have to do the whole head. In medical CTs, you really need to do the whole region. They can't do a quad. Lastly, accuracy and precision. Much more accurate than 2D radiographs. So whether it's anatomy or a procedure that you're doing like an anomaly or a jaw density that you want to check, this is very, very accurate because the slices are much smaller than a medical CT. You are getting a really, really accurate reading that you can use for surgeries, for example, for implant placement, for endo, for other things. Now, we said we're going to talk about how much radiation do they really get. So it's about 10 times less than a medical CT and about 10 times more than a panoramic, which is, again, about 6 times more than an intraoral. So about 16 to 20 times more than an FMX, but 10 times less than a CT. I hope that helps. Now, the amount of radiation that you get from a CT depends on a whole list of things you see here. Out of all of them, the clinician, you can really only change 2 things. You can use a leaded neck shield to really shield the patient so that you will only get the radiation in the area of the jaw. And number 2, you can change the FOV, the field of view. You can change it to a quad or a lower jaw instead of the full upper and lower jaw. So the less the quadrant of radiation or the field of view, and the more you shield everything around it, the less radiation the patient gets. All of the other things that you see on the list really are set by the machine and the company, and you can't change anything in them. So now it's very important that you remember when you have a new shiny toy like a CT that it is a radiating machine. You have a radiation license for it because you are radiating people. And that's why I made this kind of DJ Penchas and the devil here, because you have to remember the ALARA rule. As low as reasonably achievable. So the basis of all radiology, and any radiologist will tell you, is the ALARA rule. And that's how you really limit radiation to patients. So not all patients require a CT scan or 3D imaging. When they need it, you only want to expose only for a certain study that will be beneficial for your clinical information. So if a patient has an area that you are concerned about, you're going to radiate that area. You're not going to radiate the full arch or both arches and just say to your staff, anytime I see a patient, before I see them, I want an upper and lower CT. That is really going over the ALARA rule, and it's malpractice. So your clear objective as a doctor needs to be to establish when and how you're going to use the CT, and have you and your team understand that you should not be used as a routine basis, and it is not a screening device. So you don't have all your patients get CTs, or a patient comes and he says, I think I want an implant, and your office manager says, everybody that wants implants, we take a CT before the doctor sees them. That is against the ALARA rule and can be considered malpractice. You want to only radiate the area and for a specific reason why you are ordering that CT. We talked about the FOV, and it's really important to kind of understand what that means. It's the data volume and the amount of radiation that's going to, the area that's going to be radiated. And of course, the larger that FOV, the more radiation the patient is going to receive. You can, with your CT, go as small as a quad, but not smaller than that. Usually we'll talk about small, medium, and large. Small being the green, a quad, some area in the anterior, posterior. The medium is going to be one arch or up to two arches. And that's usually used either if the patient has a systemic problem, or if you're planning on a full arch restoration or surgery, such as orthognathic surgery, full arch implantology. And then the large one, which is the yellow, which is usually for skeletal anomalies, asymmetries, and orthognathic surgery. We usually, general dentists, never use the large field. Now, I want to add one more thing that's ethical and legal and really important for all of you to know, and that is that when you give your staff an order to take an X-ray and they decide on an FOV with you, the larger the FOV, the larger the area that you're going to get on your X-ray. And whatever area you get on your X-ray, it is your responsibility to do one of two things. Either you are going to be the radiologist and you're going to interpret that CT, or you can't, or you're not comfortable interpreting, and you have referred the patient or you referred the CT to be interpreted by a radiologist. So the reason I say this, because if you took that large FOV, you took that large CT of the skull, top to bottom, you're responsible for interpreting all the pathology in that area, including behind the eyeball, in the skull, all of the anatomy, anything that shows up on your CBCT, you should be able to interpret it. And if it's found that you actually did this and you didn't interpret it, then there's a problem. So that's why I tell people you really want to take the smallest area because I see when doctors get sued and there are questions, did you interpret this? Or what about this area? And they say, well, I'm a dentist. I don't know how to read this part. You can't say that. They've paid you to interpret. You're the radiologist. So you have to be certain you know what you're reading. So now let's get into the real heart of the matter, which is image interpretation steps. So all of the CTs today are basically dental CTs are the same. They're all going to save in a format that's interchangeable between all softwares and all machines. It's called the DICOM file. So DICOM means digital imaging and communication in medicine. It's a file that's kind of like the JPEG of X-rays, and all physicians and dentists use DICOM files. It's a format that you can handle, store, transmit, and communicate with that. Everybody uses it. It's kind of like the PDF of X-rays. Now, when you get a DICOM file, you can send it, you can save it on your drive, you can send it by email, and when somebody gets it, they're going to import it into whatever software they use to look at CTs and interpret them. And the first thing they're going to do is reorient the patient data. So the patient data comes as a set, and when you open it, you have to align it so that you have a head that's straight, not tilted, and that you can read all the planes. You know, there's several: occlusal plane, horizontal, sagittal planes, axial, and you want to get all of these planes where you can view all of them. So that's called reorienting the patient data. And you'll see in a minute an example of how we do that. We are going to select the curved slice, and then we're going to systematically read the entire comprehensive set of images. So if you have 3, 4, or 5 sets of images, axial, coronal, sagittal, you are going to comprehensively read each one. Again, the whole X-ray, all 3D of the whole area that you ordered, you have to read it. Now, one of the problems we have with CTs is image artifacts, which is usually from metal. Unfortunately, metal restorations, crowns, things like that, cause a lot of artifacts, and we're going to look at that in a minute. But I wanted to talk about that. So we talked about the first step once you open a file, and we're going to open some files in a minute. But you can see here 2 dental arches, and you can see the red line. That's the orienting or selecting the curve of the images. So the images are basically hundreds of slices. There's slices that go around the jaw, and you want to orient the line so all of the slices are seen perpendicular. And you're going to do that by putting this line. This is correct for everyone, any software that you have. And because the mandible and the maxilla are on different curves, you are going to first read one and then the other. You are going to select the curve for either the mandible or the maxilla. You can't select both at the same time. You can't really read by doing that. You have to read the maxilla and read the mandible by changing the dental arch curve to that area. And then again, you're going to read. So I'm going to show you some anatomy and talk about that anatomy with you. So we're going to start here, if you will. This is an axial view, and we're going to start with the maxillary anatomy, and we're going way up, as you can see, and we're going to go a little lower here. We've got the nose, or the frontal bone, and then we've got the temporal bone on the side, and then the sphenoid bone. And as you go down, here's the optic canal. So this is the eyeballs and the nose. We're going to go down below to the area that we start working with, which is the nose. And here's a great cut for us. So you're starting to see the sinuses. You're starting to see the sphenoid bone, the temporal bone, the nasal septum, in the nasal bone, and the maxilla is starting to show up. Here is the zygomatical area, nasomaxillary suture in the nasal bone. Here you're starting to see the sinuses, and the maxilla is going to be right up here. The pterygoid is going to be right here. So, and here's the, obviously starting the mandibular condyle. And the zygoma, if you've heard of zygomatic implants, this is the zygoma. This is where we kind of hit the implants for zygoma. Okay, here we are. So a couple of anatomical things that I want to show you close to the maxillary sinus right here, the nasolacrimal canal, which you'll see right here, the pterygoid process, the zygomatic process in the zygoma, the infraorbital canal we talked about is right here. And now we're going to get lower and lower. Pterygopalatine canal and the pterygoid. Here is the frontal process of the maxilla. Here's the maxilla with the hard palate right up here. Of course, the mandible is on the side, but it's really important to see here in the palate what you can see. So the pterygoid is where we place implants called pterygoid implants. And here's the maxilla. Right here, incisive canal. In the mandible, you're going to start seeing the mandibular canal. Of course, all the teeth. And here comes the mandible with all of its teeth. The symphysis. Right here, that little spot right here is going to be the incisive canal. Mental canal, you can see always on the side of the mandible coming out. And the mandibular canal or the nerve will usually end up somewhere around here. And then the symphysis, and we're done. We're going to look at it from a different aspect now. And please, if anybody has questions, go ahead and ask them. This is all about you. We're going to look at a coronal. Coronal is very, very useful. And in the coronal, again, you can see the nose, the turbinates, the nasal septum. This is very helpful with the sinus when you do sinus surgery and you want to see the zygoma. So it's really important to see if the sinus is open to the nose and where the meatus is. And here's the maxilla again, and the mandible, and we could see the nerve. This is the mandibular nerve. It's hard to see the maxilla, the palatine nerves or the palatal nerves in an axial or coronal. They just don't show up. But the sinuses are really seen well in their connection to the teeth. And everything around, I will leave this for you to be able to see, but it's important. Again, if you took an x-ray that has the inferior orbital fissures and the pterygomaxillary and the meatus and everything around, and you're taking an x-ray that's that high, you need to be able to read this anatomy. If there is anything in the anatomy that's abnormal, you need to refer the patient to someone that will help you with it. That's why I don't take FOVs or CTs that are that high. I leave them very, very low because I don't want to read what I'm not familiar with. Okay, so let's start by really interpreting some CTs and showing you what it looks like to interpret CTs. So I'm going to Open another software to present. So again, like I said, you can use whatever software you want. We usually use Blue Sky Bio. The reason we use Blue Sky Bio is because it's a free software that you can install on any computer and use it at home or wherever you are. And basically, if you want to use it for implants, you can plan everything on it. The only time you have to pay for Blue Sky Bio is if you actually want to print something. If you want to print a model or send something to a lab, then you need to pay for it. But if you're interpreting x-rays or you are planning, it's totally free. It's a very powerful and accurate software. Guardian Dental Partners also gives you, through Neodent, a free planning software that works very, very well. And you can all get that for any computer you want. So the first thing I did was I opened my software. And the second thing I'm doing now is I'm going to take this line, and you could see it when you get the X-ray, you can't really see the mandible or the maxilla. You have to take your axial line that we talked about, and you need to align it with the mandible. So I'm aligning it right now, and basically what it means is that your X-rays are perpendicular, as you can see here. So every single shot is going to be one of hundreds of shots of the mandible, so you can see the coronal view. Now, the MPR, as it's called, is all the panels, all the different slices that you can see. So let me show you what the slices are here. What we have here is the 3D rendition of the X-ray. We have the panoramic view. We have the coronal and axial views. And here is something that I like a lot, because as this turns around, look at the green line here, which is at 90 degrees. As you turn this, it's basically turning around that molar. It's turning 360 degrees. So you can get all of your shots in one turn. You're basically going around that area at 360. So very, very helpful. And, we go back to the 90 degrees because now we're looking at each one of these horizontal slices, vertical slices, sorry. So let me walk you around this so you're a little more familiar for each one of you. The most important thing to do is, again, to look at each one of them sequentially and read the whole X-ray. I did this today with Dr. Saab. So let's go and first look at the 3D. That's usually the one you want to go first. We talked about these, what looks like a spray around here. Anybody, what is that? Around the posterior teeth, you see all this kind of stuff flying out. What do you think it is, Dr. Saab?
Scatter.
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 So that's scatter from metal, right? Which means that these crowns are not ceramic, they're metal, and you're getting a lot of scatter. That's something that really disturbs us, but we can't do much about it. It really makes some of these shots inefficient. Now, we can reduce the scatter a little bit, but when we reduce the scatter, we lose some of the bone formation because it's moving it. So I'm adjusting some of the scatter, but you can see the maxillary bone is disappearing because it's so thin. Here we see the mental nerve. We see some of the infraorbital nerves coming out here, right up here, and right up here. And usually, remember, if something is showing in both sides bilaterally, it's usually something anatomical. If it doesn't show in both sides, then it's either very thin bone, like we have here, or it's pathology. Here's a pathology. Let's take a look here. If you all see this around here, we can see the root of the tooth, and we can see that we're missing bone around here. which means a bone fenestration, usually secondary to an infection. So we're going to look up here on the bottom one and look at what we see here. Again, we can change the clarity, the darkness. There's lots of things you can change here, but you can immediately see that this area has an abscess. And that's what I mean by looking at every one. If you put the line right at it, the coronal line, you can look at your coronal view, and here's the tooth. Here's the large abscess, and you could see that it's eaten through the buccal bone. And as you go around, you can see here's the abscess totally penetrating the buccal plate of the maxilla. So very easy to see because we're looking from very different areas, but it's very easy to see the pathology. By the way, very convincing for the patient when you say, look, there's a hole in your skull. You could see your infection is from the tooth has ruined your skull. We're going to look around to see if we see one more like that. We don't. And again, it's great because you can look around on the bottom from the inside of the patient. I just think that's so cool. But we see another abscess right down here. And let me show you. Sorry. Look at this abscess right here. Number 26. So we're going to put our line on it. We're going to go again to a different shot of it, which is our coronal shot, and look at this abscess. Now, these are findings we found on the x-ray. Dr. Saab will tell you that the question was a loose crown. These are findings that are just findings with no pathology, complaint, no asymptomatic by the patient. That doesn't mean that we would take this CT for every patient just to find stuff, but it is so many times that you look at one tooth and you find other pathologies that the patient was asymptomatic, you couldn't find them in the mouth, and you find them thanks to the CT. So now what we're looking for is the bone itself. We can measure how dense the bone is. It's in Hausfeld units. 2100 is very dense. If you look at the cortical bone, of course, you see that the bone in the middle here is only 390, and you can see that the abscess is basically the same. So lots of different features that help you understand what the pathology is like. Is it bone? Is it soft tissue? What's going on? Has it penetrated? Now, you all know that if it's penetrated the buccal plate, the chances of endo being able to fix it without an apico are lower, not no chance, lower chances, and that's well documented. But if the buccal wall is still intact, your chances of doing endo and succeeding are higher. So this is very good diagnostic tool to telling you what is your chances of success of performing endo. So great. We found on Dr. Saab several problems, several ideas. We're going to go open another case to see some other things that we can find on anatomy. And so as we save and open, you really need a very strong computer, basically a gaming computer or a much stronger workstation to do this. You can't really do this on a small laptop. What you see here is an example of a edentulous maxilla, and we're going to look around in this edentulous maxilla. On the bottom, the software can show you where the mandibular nerve is, and you can literally see the mandibular nerve down here flowing through. You can see where it enters, and you can see it here is where it enters the mandible. This is where it comes out in the mental foramen. And you can see the maxilla on top. One of the things that gives you a great idea of how much bone do I have, what is the quality of the bone, because I can use the Hausfeld units to understand, and then look at it from the side. In this shot, you can see that this bone has been grafted. I've grafted this bone. The original bone is actually just right here. And all this is mandibular bone that I've grafted or added with screws. If we look into the mandible for a minute, you all can see on the coronal part what the posterior mandible will look like. You can see the mandibular nerve is marked on it. And so, of course, you can use measuring tools to measure. You can use different options to measure not just the height, width, but where the nerve comes in. Here's the mental foramen. You can mark it. You can see this is the anterior loop moving forward from the anterior foramen. Here is still an anterior loop. So if somebody thinks, oh, the nerve just came out the mental foramen here on the bottom, we all remember that there's an anterior loop that keeps coming forward. And of course, I can mark it here myself, or I can see it just as we did right here. And we know that if we drill right in front of the mental foramen 2 or 3 millimeters, there's still a nerve there. If you extract this tooth and try to place an implant, you need to understand that the nerve is there. And there's no way to see that on a Panorex. That's just not going to happen. You can't see it here. You can only see it on this view here. Let's look at a patient and try and find MB2. As you know now, one of the great things that you can do is use this for surgical stents, both for implants, but also for endo. Blue Sky Bio has a software where you can design, or you can send for somebody else to design for you guides. They could be guides for implant placement, or they can be guides for endodontic placement. And endodontic placement means that you order a guide that has the exact drilling spots where you would drill until you reach the canal. Why do I need it? I'm not sure I can find MB2, or I have calcified canals and I don't think I can find them. They will send you a drill that is the correct size and the correct depth to where you can go almost to half the tooth, 2/3 the tooth. It depends on the curvature of the tooth. And from there on, you could either manually or with rotational devices finish your endo. But the opening of the canals and finding them will be done with a guide, with a stent. It's not very expensive. It's about $120, and it works really well for those canals where you feel I'm not going to be able to find them on my own. Here's an example of how we plan implants. This is a maxilla that is really resorbed, tremendously resorbed. It's not like that. It's really more like this. And we've designed and planned some implants. And we can move this back to see if they're parallel or where they are or what happens to them. We can also see the patient's lips to understand where this is going to come out for aesthetic reasons. But let's go and see if we can find an MB2 here. So I am going to drop this. We're going to this slice right here in the middle. And depending on your x-ray and depending on how clear it is, you can usually see the canals. Here we can see 1, 2, 3 canals. Here are 2 canals. I'm trying to find MB2 and understand what the canal looks like. Here's 2 canals. And here's 1, 2, 3. And I'm looking for MB2 in it. And there are times when I can find, here's 1, 2, 3, and here's MB2. Let me try and increase it so you could see where MB2 is. See if I can make it any larger. Let me see if I can zoom it in. So I can't zoom it in for all of you, but I can promise you from where I'm sitting, you can see MB2 right here. But on the other tooth right here, on the other molars on the other side, I can't see it. I could just see the canals and I can see how they end. And of course, you could see here 1, 2, and 3, but there's an MB2 here. Right here. 1, 2, 3, and 4. So very helpful to actually look. Now, some x-rays are going to be much clearer of the canals. Mine is an older version. Here's the palatine foramen, nasopalatine foramen. So this is more difficult for me to find MB2. Some of your machines, if they're later generation, are going to make it easier for you to actually find canals. I'll show you one more for today. So I usually, okay, let's take a look at this. So in this gentleman, we're looking at a couple of things. So let's start here. Right here, we can obviously see a root tip with an infection. We can see here some screws and a plan for an implant, but we can see some pathology, and let's look at it. So a couple of things that you can see, and again, remember, you are the diagnosing radiologist. So if you see any sort of a problem in the sinuses, it's up to you to either refer or diagnose and treat the problems. So you need to kind of start understanding deviated septum and sinusitis. If you see this patient here has sinusitis in his left sinus compared to the right, you could see that it's pretty much a normal sinus. The Schneiderian membrane in some of them, especially if they live in Houston where there's sludge in the air, can be very thick, but they're not going to have sludge inside. You can see that right here. It's really thickened. It's much more opaque, and this is typically a view of somebody that has sinusitis. Again, you can refer to the ENT for sinusitis, or you can give them some medication for it, but you have to tell them and ask them, do you feel this sinus is giving you problems? Is it draining, not draining? I recommend you see somebody for it, and you can write that in the chart that you saw something was wrong. Same thing here with this pathology. Let's take a look at it. We're going to put the line on it. And we're going to look up here. And basically what we see is, like I told you, that this patient has sinusitis. You'll see that again and again. all of this stuff, all this sludge that you're seeing in the patient's sinus, that's sludge from having sinusitis. There it is, totally full. His sinuses are full. This is the plan for an implant. So you could see we've placed screws and we've grafted this patient and we're getting them some implants. So one of the things you cannot do with CT, again, I see a lot of doctors saying you have decay. You have a cavity. This is a cavity that you have, and I've diagnosed this on a CT. Cavities usually cannot be diagnosed on CD. So tooth pathology in terms of dentin and enamel cannot be diagnosed very well on a CT. Don't try. That's the wrong thing to try and diagnose. But endodontics in terms of finding MB2 and things like that are very, very helpful. So we're trying to look up here. Let's look here. Here's canals, and you can start seeing where they're going and what they will end up looking like at the end here. And this is usually what tells me when I get close to the apex, tells me how many canals I really have. 1, 2, 3. And I get the idea of 1 and 1. And I get the idea at the end of where the canals end up. So if the patient has sinusitis and it hurts their molar, I'm able to determine what is going on with this molar because I could see if it's really in the sinus, like this molar right here. Is it really in the sinus or is it outside the sinus? Look at this. This molar is right in the sinus. And so you can easily understand where if they blow their nose, if they have sinusitis, they can really have a toothache from the sinuses. Very helpful in diagnosing when patients tell you that they have a terrible toothache, but turns out it was from the sinusitis. Again, I can look at their 3D. And see if there's any bone problems. Again, we talked about infraorbital. We talked about perio can be diagnosed or helpful to diagnose, but not diagnosed. And then thickness of the bone. So that's about it for this idea of reading for today. What I challenge you is to learn how to read these. I've sent you, I've invited you, and I've added a book, a CBCT book for you to read in a hands-on class. If you're interested in really learning how to read them, and this book that I sent you and working with me is not enough, you can always call me, send me a CT, we'll work through it together. But for a hands-on class, there is a new class in Gainesville, Florida that you can join and see. And I've sent you the information for it right there. It's a course that provides really everything you need. And it's really hands-on. It's 2 days. But my recommendation is if you need anything, send me the CT, schedule a time with me. We'll walk through it. We'll see it together and we'll figure it out. Any questions? Dr. Saab, anything? Dr. Tron, Dr. Jones?
No, I think I'm good.
That
was very helpful.
Same here.
Great. So anything you need, let me know. I'm here to help and serve. Have a great evening.
Thank you. You too.
Thank you. Thank you too.
Meeting over.